Good evening, everyone. I'm Dr. Timothy Ott. It's 7 o'clock now. I'm sure we will still have some more people signing on, but I'm going to get started with our housekeeping stuff to respect everybody's time as we move forward. Thank you for joining us tonight for implicit bias training presented by Dr. Haynes and Dr. Rembert. This is a statement from the IAFP's values that we will support diversity in all of its forms, and that's one of the reasons why we support implicit bias training. Some news events. Saturday is the last day to pre-register for FMX. The national conference in Chicago this year in October coming up. So if you haven't already registered, please register for FMX. There is free registration for FMX for Illinois residents. The code is there for that. The early bird discount ends on Saturday. We are holding our annual meeting alongside of FMX because we didn't want to have a separate event and try to compete with that. There are 3 awards that we give out every year: Family Physician of the Year, Family Medicine Teachers of the Year, and the Vince Keenan Award. There's a link to the website there if anybody would like to nominate for any of those awards. Housekeeping: all attendings will be on listen mode only. PDF of the slides and other resources can be found on our website, and I believe that information is shared in the chat to get links to that. If you have a question during the presentation, please enter it into the chat. We will hold all the questions until after the presentation, and then I'll make sure our presenters get the opportunity to answer all the questions. This presentation is being recorded. All discussions and questions will be part of the final recording, and the final recording will dwell on the IAFP's website for future use. The Illinois Licensing Bureau now requires a number of different CME things, and one of those is an hour of implicit bias training every cycle. This hour that we're presenting tonight will count for that. So we're happy to provide this for you in that regard. Accreditation: we offer 1 hour of prescribed credit with the AAFP, and our accreditation is through ACCME and the IAFP. You can also get 1 hour PRA credit, both for the live version or the online enduring version. At the end of the presentation, you will be emailed a post-test, and if you complete the post-test and fill out the evaluation for the webinar, then you will get a certificate for your CME. Disclosures: we have a full disclosure policy that you can read there. Both of our presenters, myself and our 2 staff members, report no relevant financial relationship or interest with any proprietary entity in regard to tonight's presentation. Support for this presentation is from the DuPage County Health Department, and we appreciate their grant to help this CME. And now on to the presentation.
Hello, everybody, and welcome this evening to our implicit bias training with the Illinois Academy of Family Physicians. My name is Dr. Ronald Rembert, Jr. I'm joined by Dr. Andrea Haynes. Dr. Haynes is a graduate of Warren Alfred Medical School of Brown University in Providence, Rhode Island. She completed her family medicine residency training at Tuscaloosa Family Medicine Residency Program in Tuscaloosa, Alabama. She also completed a high-risk obstetrics and cesarean section training at PCC Wellness Center in Chicago, Illinois. She's a board-certified family medicine physician with active experience practicing full scope of family medicine, including surgical obstetrics in the inpatient and outpatient setting at federally qualified health centers and community hospitals. She also manages acute, chronic, and mental health disorders, as well as provides preventive visits for newborns, as well as older children and our adults as well. She has expertise in community organizing and collaborates with African American churches, non-for-profits, legal partnerships, and schools on various public health issues. And I'll tell you guys a little bit about myself as well. I'm a family physician with experience treating the underserved with acute and chronic illnesses. I've been an assistant clinical professor in the Department of Family Medicine and was co-chair of the Community Advisory Review Council reviewing community medicine research projects at the University of Chicago, and an instructor to medical students at Rush Medical Center. Currently work as a consultant to healthcare organizations around the country, and I've been a trustee with the American Association of Public Health Physicians, currently serving on the Family Health Foundation of Illinois Board and the Board of Age Options. I received my medical degree from the Chicago Medical School at Rosalind Franklin University of Medicine and Science, and completed residency at Rush Medical Center and Advocate Illinois Masonic Medical Centers, and served as chief resident during my last year of residency. So with that being said, let me go ahead and share my screen and we'll get started. So welcome to our implicit bias training this evening. And let me outline our objectives. We want to understand the difference between explicit and implicit bias. We want to look at the causes of implicit bias, including how these biases form and operate. We also want to understand the effects of implicit bias and the harm it causes, and work to develop and implement strategies to recognize, interpret, and mitigate implicit bias. So our first objective, to understand the difference or differences between implicit and explicit bias. So what is implicit bias? According to the NIH, implicit bias is a form of bias that occurs automatically and unintentionally, but nevertheless affects our judgments, decisions, and behaviors. Research has shown that implicit bias can pose a barrier to recruiting and retaining a diverse workforce, among other things. So let me give you some types of implicit bias, and this list is definitely not exhaustive. There's beauty, which has assumptions about people's skills or personality just based on their physical appearance, and a tendency to favor people who are more attractive. Confirmation bias, which selectively focuses on information that can support your initial opinion. There's horns bias, which focuses on a particular negative aspect or feature about a person that clouds your judgment. Attribution bias, which is a tendency to attribute other people's success to luck or help from others, and their failures on their own personal shortcomings. And anchoring bias, a tendency to rely heavily on the first piece of information that you're offered when making a decision. Now, as I mentioned, there are many types of biases. This outlines several types, including internal, external, and organizational. And it's a busy slide, but it gives a better sense of the many types of biases that we face and can carry with us. So what is explicit bias? Explicit bias is the traditional conceptualization of bias. With explicit bias, individuals are aware of their prejudices and attitudes towards certain groups. Positive or negative preferences for a particular group are conscious, and overt racism and racist comments are examples of explicit bias. So in this slide, we outline the differences between implicit versus explicit bias. Implicit bias is usually expressed subconsciously. For example, asking a woman if they have a boyfriend, assuming heterosexuality, associating obese patients with cultural stereotypes, such as being lazy, or viewing people with disabilities as having a lower quality of life. Explicit biases can typically be expressed directly. For example, a chief of a department does not hire a woman because they don't believe that women are strong enough, or stating during a sign-out that a person experiencing homelessness is drug seeking because they see it all the time, or stating that older adults should not drive because they cause wrecks. In this particular slide, we look at socially acceptable versus socially unacceptable racism. And in socially unacceptable racism, this is acts that many people would consider negative and would never consider doing typically, including violence and calls for violence or even murder and genocide. But with socially acceptable racism, these are typically more subtle and sometimes harder to distinguish, but can have a profound effect on people, not only in terms of their interactions with one another, but can lead to discrimination in terms of access to healthcare, access to housing, access to education, and access to just equal rights in general. So some socially acceptable racism includes discrimination, veiled racism, minimization of people's feelings, as well as just having indifference. Now, this slide shows some reflections where certain statements can possibly be related to these different categories, and I'll give an example. If I ask to talk to the person in charge, I'll be facing a person similar to me. And some of the related social categories include race, ethnicity, gender, and sexual orientation. But it's a way of looking at how the way that people think, act, and live their lives with their own implicit biases, how it affects how they interact with others. Now, for our second objective, we look at the causes of implicit bias, including how these biases form and operate. So how does implicit bias form? According to the American Psychological Association, they state that implicit bias is thought to be shaped by experience and based on learned associations between particular qualities and social categories, including race and or gender. So some of these things that influence implicit bias include life experiences, family, social media, friends, including people in the community, as well as television, among other things. Now, at this point, I'd like to turn it over to Dr. Haynes, and we're going to look at objectives 3 and 4.
Okay, so far we've learned about the difference between implicit and explicit bias, as well as how these biases form. So to continue to build on that, objective 3 focuses on understanding the effects of implicit bias and the harm it causes. So the next couple of slides in particular go over articles that explicitly state how implicit bias plays out in the healthcare system. So this article it is entitled Implicit Racial Ethnic Bias Among Healthcare Professionals and Its Influence on Healthcare Outcomes. This was a systemic review that was done in 2015. And it stated, the gist of the paper stated, most healthcare providers appear to have implicit bias in terms of positive attitudes towards whites and negative attitudes towards people of color. Future studies need to employ more rigorous methods to examine the relationship between implicit bias and healthcare outcomes. Interventions that target implicit attitudes among healthcare professionals are needed because implicit bias may contribute to health disparities for people of color. And so this was, the research really started around 2015 and it's continuing to build today. Next slide. So in this article from 2019, it was about detecting implicit bias in provider communication behaviors to reduce healthcare disparities. And this paper noted that the identification of specific provider communication behaviors that mediate the link between provider and implicit racial bias and racial ethnic minority patient outcomes, researchers can begin to fully develop culturally respectful and personally tailored communication skills, training, and other interventions to reduce racial disparities in healthcare and health. Again, continuing to build on. This is certainly an evolving area where more research is done daily to contribute to help target interventions to working towards this, but there's definitely been a connection that shows implicit bias and the impact that it has on health disparities, in particular for communities of color. Next slide. And so again, just highlighting some more patient outcomes related to implicit bias. So the first article there on the left is from the American Journal of Public Health in 2008. It stated race plays a significant role as a determinant of health in the United States. Racial disparities are associated with all-cause and infant mortality are larger than they were in 1950. The presence of racial inequities in health must be understood through the persistence of the racialized social structures. So we can't talk about implicit bias without taking into the social determinants of health and race, and of course the systems that have been developed from that. Even though we're specifically highlighting in this article about race, as Dr. Rembert mentioned on our previous slides, especially in Objective 1, there are many different types of biases as well as diversity dimensions. And so even though we've highlighted race here, please don't forget about that diagram that showed the internal, external, and organizational dimensions of implicit bias. Okay, over on the right side, there is, this was from a journal article in 2022. This specifically related to the field of dermatology. So there's evidence to suggest that socioeconomic factors, lack of access to healthcare, and the presence of bias and deficient skincare education among non-white populations, as well as physician trainings, may contribute to the disparity in the mortality rates related to melanoma in these groups. These findings apply to other areas of medicine besides dermatology, where patients of color are at an increased risk of poor health outcomes. So again, highlighting how implicit bias does impact patient outcomes. And this is played out in the various fields of medicine. Next slide. So what are the effects of implicit bias? So this is really like a cyclical development in terms of it impacts the patient-physician interaction. And so that goes both ways, how the patient feels that they are perceived by the physician, how the physician perceives the patient. Also, it can affect treatment adherence. If the patient is not feeling respected, heard, or if they are picking up on bias that is present, that could affect whether they adhere to the treatment that is being recommended. Also affects health outcomes. On the previous two slides, highlighted how implicit bias does impact the health outcomes. And so this also can lead to patient satisfaction. Were they satisfied at their visit? How did they feel about the care that they received? Was there something that they wanted done differently? And then, of course, the inequities in care that we see, especially faced by those in Black and Brown communities. And certainly with the health outcomes in particular, this is not where I'm saying there is a racial or genetic difference between, say, Black and white populations. I'm simply stating that it comes down to bias and racism. So getting into the meat of this presentation, Objective 4. So we've focused on what is implicit bias, how does it form? We know the impact that it causes on health outcomes. So Objective 4 really gets at, okay, we recognize this. How do I develop and implement strategies to interpret and mitigate these biases? So first, it comes from recognition. So self-evaluation and reflection. Not sure if many of you have heard about the Harvard Implicit Association test. This is a test where you can do simply on your own, various categories, but it can be done for you it serves as a reflection to see if you have any biases about anything in particular. Dr. Rembert here is showing, he was generous enough to show the results of an implicit association test that he completed. And I'll allow him to explain his results right now.
Okay. And on this particular slide, there's a link to the site associated with Harvard that provides various implicit association tests, including gender, race, and other areas where you can basically self-surveil and test yourself to see what implicit biases you may have. When I took the implicit association test, I did the race portion of the test that they provided. And the response that was given suggested that there was no automatic preference that I made between African Americans and European Americans. And it uses photos and your response to those photos or questions to come up with the response. Afterwards, they'll give you these results as well as the percentage of the respondents with a particular score. And it's broken down for this particular IAT with either a strong automatic preference for European Americans compared to African Americans, moderate automatic preference, slight automatic preference, little to no automatic preference, as well as slight automatic preference for African Americans, moderate automatic preference for strong automatic preference. Now, when you take the IAT, there is a link where you can actually email the creators of the test if you do have questions. And basically, it's to give you a sense of where you're at, as well as ways that you can look at your own implicit biases and begin to address them.
Will you go back one slide, Dr. Rembert?
Yes.
And so as Dr. Rembert stated, this is for your knowledge to recognize. Oftentimes we know with implicit bias, sometimes these are not things that people readily acknowledge in themselves. And so this can serve as your source of reflection and evaluation. Additionally, we will provide, there's a self-reflection survey that you can complete as well. We'll provide that. And it serves as a way for you to, there are several statements related to like clinical medicine and ways that you can evaluate, thinking about what have I done over, say, a certain time period, whether that's 3 months or 6 months, related to implicit bias or working on my biases. And then also the last thing is building empathy. Okay. So other ways to intervene. So the first way, so building new associations. That involves, what we mean by that is collecting information that is opposite of the cultural stereotypes that you may possess. And so this involves increasing your opportunity where you have contact with individuals of different groups, really challenging that stereotype that you hold. And then in particular, also using a team approach. And that's working with various people on your team that have different diversity dimensions, but that's as well as different departments to really create a more organizational approach. Okay. On these next two slides, I want to specifically spend some time talking about what are some institutional mitigation strategies. So I know everyone may not be currently practicing in clinical medicine. They may be in a more administrative role. And so I wanted to spend some time in particular talking about the hiring process. And so there are a couple different areas that we'll focus on. So the first one is a non-biased interview process. So what do I mean by that? That's considering the policies or procedures related to the recruitment and the selection and onboarding of applicants. And bias can be present in all the different areas related to that, such as the text of the application, the candidate summaries, or during conversations with other interviewers. And really creating a non-biased interview process, really looking at a specific criteria that you're using to evaluate applicants. Also considering, broadening out where you normally send your job announcements. And then in particular, oftentimes during the hiring process, there is a committee involved. And with the committee, really holding to where everyone will give their opinion at the end. So after every interviewer has interviewed the interviewee. And in particular, if a person does not rate a particular applicant highly, having objective measures or really challenging that person to say objectively, what is it about this applicant that why they would not be a good fit, instead of just allowing, oh, well, I don't think they'll be a good fit. Well, really challenging what objectively is why this applicant might not be a good fit for us. Another thing, a part of that is avoiding candidate descriptions that could trigger a bias in someone else or even reflect like your own bias. So these could be statements such as like, oh, the candidate is very smart, or this is the perfect candidate. And so it can lead to some of the bias that Dr. Rembert mentioned earlier, whether that's anchoring bias, such as like, you're like a perfect candidate. Well, there's not any flaws with this applicant. Things like that. And then as an interviewer, like recognizing the signs of when like your bias has been triggered. So how do you know when your bias has been triggered? That might be where you feel a sense of annoyance, or your heart rate is starting like to race, or you have a negative viewpoint after a resume or an interview. This is the time where you can take a moment. Hey, let me check. Why am I feeling this way? What is going on here? And it just serves as a moment of pause to reflect. And we'll talk about that a little bit later. And then the last thing is only mentioning a diversity dimension if it is like relevant to the communication. So in considering all the different types of diversity dimension, only mentioning it if it is relevant or applicable, not just as an adjective to describe that person. Okay. And then on this slide, I go over a few more institutional mitigation strategies. Here are 5 things that organizations as a whole can take to mitigate implicit bias within their organization. So the first is diversity, equity, and inclusion training, DEI training. And so DEI training specifically focuses on the diversity dimensions, whether that is race, disability, any dimension, sexual orientation, and it also involves allyship training, and even like bystander communication. So what do you do when you see a coworker who may be exhibiting implicit bias? How can you work to bring that coworker in and show that, okay, this is what I observed. This is how this could have been done differently. The next step is something called equity coaching. This is really about the process, strategic planning, tactical coaching. And so specifically with equity coaching, this is a coach who really works from an equity lens. And so certain questions or things that the equity coach can answer are such as, how does the organizational policies and procedures, how are they reflecting equity? How is the current organizational setup hindering my role in whatever that role is? And then it also works to identify, specific leadership behaviors or ways to improve from there. The next is developing DEI metrics. And so in any time with any of this, in order to really determine if the outcomes are effective, if you are seeing progress as an organization from this, you need metrics. You need some way to measure your outcomes. A lot of the outcomes focus on demographics, but not just demographics such as, 52% of our providers are women, for example. It's looking at more specifically, okay, of that 52%, how many are in senior leadership roles? How many are working part-time? How many are working full-time? Or if you have various site locations. So looking at it more specifically than just as one broad number. Another thing is also looking at the demographics of your applicant pool. Looking at the demographics of your senior leadership. Does your leadership reflect the patient population that you're serving? Does it reflect all members of your organization? And so that's where the demographic data comes in and allows you to really look at it on a more singular level. Also looking at your organization's retention. How many workers are you retaining, and looking at those demographics. Other demographics include things such as employee satisfaction, also looking at your accessibility. So that's related to those who have physical, who need physical enhancements or hearing, and does our like the physical sense of what the organization is, does it reflect, are we accessible? And then also looking at specific policies. Okay, do we have policies that are for parental as well as maternal leave? And then recognition of the various cultural and religious holidays if necessary. And then the last thing related to under DEI metrics is something looking at your vendors or the particular your community partners. And so are they local? Do they represent, have you gotten vendors or have you attempted to get vendors from the community that you are serving? Number 4 involves acting on these DEI gaps. And so after you have obtained these metrics, you've noticed things that can be improved, as an organization working to act on those areas. And then overall, this is a thing that you're always working towards, but evaluating the culture, the clinical and organizational culture to be sure that it reflects equity. So over the next few slides, we will specifically talk about implicit bias. And these are ways, so we focus on like the institutional things that you can do as a whole, as an organization. These next slides focus on what can I do as a person to mitigate my personal bias. Implicit is the acronym that I will use, and we will go through the various letters now. First, I, introspection. So this involves exploring and identifying your own prejudices and in taking implicit association tests and other means of self-evaluation. So again, that's like the Harvard implicit association test that we mentioned earlier, as well as the self-reflection survey that we will provide afterwards. It really does involve you taking a look to identify what are your own biases, because if you can't recognize it in yourself, how can you act on it? Next, mindfulness. So people tend to give into their biases when they're under pressure. So finding ways that you can help reduce your stress and increase mindfulness goes a long way. There's something called slow thinking. So a lot of times, depending on what clinical setting you're in, it is very important to make associations maybe quickly, especially if, say, you're in an emergency room. However, that does not necessarily sometimes take into account, say, the whole patient. There's something called slow thinking that involves slowing down. So say, for example, with slow thinking, if I told you, or if I asked you, what is 2 + 2? Automatically, without thinking, you're going to say 4. It's just been, drilled in you since childhood. But if I were to say, I don't know, 544 times 43, that's going to take a moment for you to slow down and actually think about it. So applying that same logic to medicine, so that involves you, okay, I have this information. I know I'm stressed. I know I'm rushed, but let me slow down and actually look at what's in front of me. Am I relying too much on a bias? Am I anchoring in on something? Have I considered all the dimensions? This is what slow thinking is about. So P for perspective. So this stands for perspective taking. So considering the experiences from the point of view from the person being stereotyped. So really putting yourself in the other person's shoes. You can do that right in the moment while you're there in the clinical situation, but you can also do this outside of the medical setting. So that involves reading or watching content that discusses those experiences that really challenge those experiences or stereotypes that you have. Also by directly interacting with people from those groups who you might have a bias toward. And it's really about challenging or breaking down that thought, really working to move from what your first reaction might be to, okay, I'm going to intentionally consider this from their viewpoint. I'm going to intentionally challenge those thoughts that I have. So L, for learn to slow down. This goes with the mindfulness or like the slow thinking, but it involves interacting with people from certain groups. It's important to pause and reflect. And this is done to reduce like your knee-jerk reaction to something. And this is also considering positive examples from people such as public figures or personal friends, but just slow down. You have time to just pause and reflect before responding. I, individual. So this is looking at people based on their personal characteristics instead of the groups that they're affiliated with. So what do I mean by this? Maybe you hold a bias or a stereotype about a particular group as a whole. With this involves looking at that person right there in front of you. What are their personal characteristics? Or if you're like, I'm not sure if I have anything in common with them, finding some way or something where you can connect over shared interests. Or even if you can't find one, valuing the difference between you all, but really looking at that person as a person, not as you know, a generalized group or generalized stereotype or biases that you have. C, this stands for check your messaging. So as opposed to saying things like, oh, we don't see color. This involves using statements that embrace multiculturalism and the differences. So because with this statement here, the earlier diagram in the presentation related to the iceberg, this actually falls under one of those categories. You can look back under it, but it can come off as dismissive or you're not seeing that person. And so really checking what you're saying, while the intent may not be to sound dismissive, but considering how it could sound to someone else. So welcoming that you all are different and also respecting those differences. Okay. I, or the second I, fairness. So working to support a culture of diversity and inclusion at the organizational level. That's why we spent some time talking about the hiring process and the other practices that you can do at an organizational level. Because while this, we're specifically focusing on ways where you can mitigate your personal bias, in order to really affect change, it has to come through the different systems as an organization. And so being sure that your organization supports a culture of diversity and inclusion. And also being sure that you are doing this through an equity lens and working to identify like your group's blind spots. So when I say working through an equity lens, I'm going to use something, it's called the 5 Ps. And so these are the Ps that you can consider when you're thinking about, okay, well, how do I work through an equity lens? The first is P. I mean, it's P, obviously, but P for people. And that is, who are the people that are positively or negatively impacted by this particular decision? P for place. So what are the distribution of the public resources? What is the environmental impact? Who are our programs supporting? 3, process. So this is looking at your processes to see who are we including, who are we excluding, and this is both intentional and unintentional. The 4th P is for power, and so that's accountability, and then also looking at your decision-making structure. And then the last P is purpose. And so this is, if you take the approach of your organization, you're committed to the mission of DEI, that P, purpose, should always serve through all of the policies and initiatives that you are pursuing. But definitely keeping in mind the people, the place, the process, and power. And then the only other thing that I did not mention on the last slide, this also involves looking at your waiting area or your patient facing information that patients receive. Are these images diverse? Do they reflect the patient population that you serve? Is anything in your office further going towards a bias? Or, is your office accessible? So looking at it from that way, really wanting to practice fairness across the board. All right, so T. So this is the last one, take 2. So resisting implicit bias is a continuous lifelong process. Even though we're all here on this training tonight, I'm glad that you're all here. This is a lifelong process. This is something that is continuous, where you have to continue to work to improve. And it will be times where the process is frustrating, but continuing to find ways to improve and challenge on those implicit bias. But it is something that we all have to work towards to be sure that we are challenging those implicit bias. Because as we learned earlier, these are formed through all of various our life experiences and other things. And so this is the combination of things throughout your life. And so it really takes time to break that down. All right, so I will recap the objectives. So tonight, so far, we've learned about the difference between explicit and implicit bias. Implicit bias meaning subconsciously. Explicit, that's more directly. Most people are able to point out explicit bias readily, meaning it's things that are obvious. Implicit bias, unconscious bias, those are the ones that are a little more difficult. Also, the next objective, building on that, it looked at the causes of implicit bias and how they form and operate. So we talked about whether it's the life experiences, TV, family, that all go to how these implicit biases form. And then how they operate. We spent some time talking about the patient outcomes and the impact that implicit bias has on patient outcomes. Then we also talked about understanding the effects of implicit bias and the harms it causes. Again, getting into the patient outcomes, but also focusing on that cyclical diagram. So that patient-physician interaction, the inequities in care. Those are some of the things of the harms that it causes. And then lastly, objective 4, this really focused on develop and implementing strategies to recognize and interpret and mitigate your own implicit bias. We talked about ways as an organization that your organization can approach mitigating implicit bias, but then we also use the acronym Implicit to go over how to mitigate your personal biases. And so at this time, we will take questions from the audience.
Hi, this is Dr. Ott. I'll start out with a question. Thank you very much for your presentation today. I certainly enjoyed it. I hope our other viewers enjoyed it as well. You were talking about implicit bias, and I really appreciate that. But what could you take a minute to comment on systemic bias?
Definitely. Systemic bias is what we see occurring, and I'll give for an example, say in healthcare, where we see people of color, people of lower socioeconomic status, people in the LGBTQ plus community or other communities that may be marginalized, having less access to healthcare and other resources in society from some of the systems that have been put in place. Some of those systems may include requiring, insurance to be seen, and in some cases for our patients who come from lower socioeconomic status, many of us have insurance that's associated with having a job. And if you're unemployed, you may not have healthcare insurance and may lack access to healthcare. Or you may have insurance, but may have co-pays or other payments that may be associated with being seen by a healthcare provider. And that may be a barrier to being seen. But if we extrapolate that across our society, we're seeing these inequities in housing, where in certain areas there's such housing inequities that we're seeing homeless populations increasing significantly. We're seeing it in the educational gap in certain areas where, depending on the zip code that you live in, the public school that our children go to may provide either a better or worse education and better or worse preparation for a career down the line, or just in general to be able to become a productive person in society. So it's looking at all of those systemic factors and how they play a role. And for us in healthcare, how we can approach mitigating some of those biases and mitigating some of those lack of accesses by changing the way that we approach healthcare. As I mentioned, Dr. Haynes works at a FQHC, and I've worked at FQHC as a federally qualified health center, which are health centers specifically geared towards our indigent population. In many cases, providing sliding scale programs for patients without insurance, providing low-cost pharmacy services on site where they can get certain prescriptions for $4, low-cost lab testing, and basically increasing access by providing low-cost alternatives to, going into a clinic, or say going into an emergency room or urgent care, where typically you would need insurance or face paying a high bill just for being seen.
Thank you very much. A question from one of our listeners is, with increasing demands on family physicians today, how can one ask providers to slow down when you have less than 15 minutes to spend with the patient?
Right. So I'll address this. It's the ever problem with a lot of things in medicine is time. And unfortunately, this is where this gets at like the organizational challenges, but taken away from the organization from a standpoint. When I mentioned, or when we talked about slow down, I'm not talking about spend, say, an extra 5 minutes. I'm talking about really slow down from that initial knee-jerk reaction. Have you considered something else besides what first popped into your mind? Have you looked at the other areas that make up like all the dimensions of this patient? And so that could mean something as, okay, you have somebody coming in for abdominal pain, and then you automatically like, okay, well, they're young. This is probably a younger patient. This is probably GERD. Well, okay, before it could be that, but just quickly taking a moment to, okay, have I really assessed this situation? Have I considered everything? And so that does not take too much additional time, but it's just pausing for just a moment to challenge that first reaction or your first thought, not to anchor on what that particular diagnosis is.
Thank you very much. Another question from one of our listeners tonight. To your knowledge, is the American Board of Family Medicine or ACCME tracking DEI metrics in residency programs in the U.S.?
Well, I know that the ACCME is taking a look at DEI and the metrics associated with it in residencies, but there's not a particular measurement that they're looking at that residency should attain. For the ABFM, I can't speak to that. I don't have any knowledge that they are looking at DEI metrics in residency programs. Now, in terms of external governing bodies to assist organizations in addressing these issues, I know that the Equal Employment Opportunity Commission is a federal agency that does look at discriminatory practices in terms of employment discrimination. There are other entities also that, including licensing entities for our states, that can also be governing bodies that can assist organizations in assessing this. But typically in those organizations or with those organizations, there's a formal complaint process that needs to be undertaken, and then an investigation that takes place after that. So it typically is more reactive than proactive. And what we're looking at this evening is proactive ways in that we can begin to address some of the inequities and biases that we see, not only in our clinics and healthcare organizations, but even in ourselves.
And I'll just add on that real quick, Dr. Odd. So
Sure.
Currently there are not, at least to my knowledge, any specific DEI metrics. Again, this is an evolving area, meaning research is being done now. People are trying to determine what are the best processes. But I can just speak a little bit on what some residency programs are doing. Again, this is not as a whole from like ABFM or ACCME, but really looking at, okay, what is our applicant process? So still being able to use some of those things that we talked about under the institutional mitigation strategies. What does our applicant pool look like? How are we ranking applicants? In particular, one thing with residency programs that's commonly done through a lot of programs is the day that you're ranking all of the applicants, like the applicant's picture is put on this large screen, and then their various characteristics on the side. So really challenging yourself, is the picture necessary? Because does this trigger bias in someone else? And then thinking about those characteristics that you have used to describe the applicant. Is this adding to it? Could this trigger someone else's bias or your own bias? And then also I say to residency programs are looking at, okay, what are the programs that we're offering? How are we involved within the community? Does our website reflect diversity? And then as well as that includes attendings. We know that oftentimes there are not a lot of Black attending physicians or in academic medicine. And so really looking at that as well are some ways that you can look at the DEI metrics in residency programs.
Dr. Orgain asks, how do we address care provided in community hospitals with poor ratings as an example of both biases?
Well, I know of personally an instance that's an ongoing process even now in community hospital on the south side, Roseland Community Health Center. I know that there have been some formal complaints that have been made and even investigations that have taken place, and not just at Roseland, but some other community hospitals as well. But in this particular case, I know that organizations such as the Cook County Physician Association, which is a part of the National Medical Association, the largest African-American medical association in the United States, they've been advocating for change in these community hospitals and working with community organizations to not only review some of the practices that are taking place there, but in some cases helping to look into some of the changes that need to be made, especially at the administrative level, but also in the care that's being received by people in those communities.
Thank you very much. Sort of a modification of a question that was asked earlier. I work for Southern Illinois University, and the dean of the medical school says they want to be they want to be an anti-racist institution, which is actively opposing racism in all forms. And so how do you suggest that people at institutions, hospitals that aren't really addressing this, how do you suggest that people that might be listening today move their organization towards an anti-racist organization?
by making sure that you have people in the community, especially people of different cultures and backgrounds, sitting at the table in those organizations, helping to make decisions for the community. If everybody is able to sit at the table and help in these decision-making processes, from not only who's being hired in the C-suite to who's working in the hospital or working in these centers, that will help to inform those decisions, so that not only will you be anti-racist, but it would be a better representation of the community, and more likely more successful in that community, because you'll have more buy-in from the individuals in the community, feel they have a voice and are being heard in that particular institution.
So somebody mentions that Kaiser Seattle Family Medicine is making a concerted effort to make their interview process more DEI friendly. Are either of you aware of a process where residencies can share best practices to make their process more DEI friendly?
Yeah, I'm not aware of any process at the moment. A lot right now is where programs are working in silos. And so certainly I think taking the opportunity when we are meeting together as a group, talking with your colleagues across, whether it's the state or nation, about, okay, what are you all doing at your program to address this, and then working that way. I don't know yet if the ABFM or the AAFP are working toward providing an outline for programs, but hopefully it may be something that's coming in the future to provide more of a framework.
Also, I would suggest with programs like Kaiser Seattle Family Medicine, if they're successful in what they're doing in recruiting a diverse residency program and producing a diverse physician pool that is going back into their community, share those findings and those methods with the ACCME. I know that they have a DEI leader by the name of William McDade, who is working with residencies and programs all over the United States. But I know that Dr. McDade would be more than pleased, along with his team and staff, to work with organizations like these to replicate provable and deliverable measures that can benefit residencies all over the United States.
And I know the National Academy, the AAFP, is always open to posters and presentations at their conferences for best practices on those sort of things. I'm hoping we'll see more of that at FMX this year. Somebody just said that, yeah, FMX is coming to Chicago, and hopefully we'll see more on this sort of training at FMX. Any other last minute comments? We're just about out of time. All right, I want to again thank our speakers. The code for free registration for residents is in the chat. The post-test link is in the chat. I would like to remind everybody to complete the post-test and evaluation to get their CME. And thank you again to our speakers. Good night, everyone.
Good night. Thank you all.
Thanks, everybody.